So I think it's just called rear-facing car seats in the Dropbox, if you guys have it up. This was an article in the Journal of Pediatrics, rear-facing car seat safety seat use for children 18 months of age, prevalence and determinants. We've looked at articles from the Journal of Pediatrics before, but it's got an impact factor of 3.89. This was actually an article in press, but was published this month in the journal, and came online in July 2017. The authors of the study are all out of a group out of Portland, Oregon, and the first author, it looks like they have done a fellowship in PICU, but I think the second author is like one of the main investigators and has an interest in injury prevention, and then one of the last authors has an epidemiology degree. In terms of conflicts of interest for the authors, it's interesting that they declared no conflicts of interest, but the second author said that he is like an unpaid consultant for a bunch of car seat companies. Not sure why like companies that produce car seats get unpaid consultants, but that's
his way of saying he doesn't.
His job. So I think it is a potential conflict of interest because maybe he is a currently paid consultant for one of those companies that he worked with. In terms of the author's qualifications, they're all pediatricians or epidemiologists, as I said. So in terms of the rationale for the study, in 2011, the American Academy of Pediatrics changed their recommendations about car seat use, and they started to recommend that children up to age 2 should be remaining rear-facing in their car seats. Prior to that, the recommendation had been that children up to 1 year, and then they had a weight and height cutoff, should remain rear-facing, but there was new evidence in, I think, 2007 that showed that children were 75% less likely to die if they were in a rear-facing car seat versus a forward-facing car seat in that under age 2, and so they changed their recommendations. Interestingly, I looked at our CPS guidelines, and CPS put out a statement in 2008, and their recommendations reflect what the AAP recommendations were in 2008, that they recommend children are rear-facing until 1 year or 10 kilograms, so in 2011, the AAP changed the recommendations, and these authors were interested in seeing what the uptake of the new recommendations were in their population. It seemed that there had been some initial research into this area that showed that the prevalence of rear-facing car seat use up to 2 years was in the range of 13 to 27%, and these authors wanted to know what the prevalence was in their population and also what the determinants of that were. So what factors went in to having children rear-facing up to the recommendation. So they decided to get at this with a cross-sectional telephone survey, and we'll talk about the pros and cons of that in a second. And really the age that they were looking at, so their population of interest was infants 17 to 19 months. They used this telephone survey as their intervention, and their outcome was really whether or not they were rear-facing at the time of the survey. They got ethics approval appropriately through their institutional ethics review board. In terms of the patient selection and inclusion criteria, so they targeted all children who were born at their university tertiary hospital between November 2013 and May 2014, so not actually that wide a range. They had to be discharged from the maternal birth unit And so in order to be part of that unit, you had to be greater than 35 weeks gestational age, and you also had to be a well infant. So I think if you were in the NICU, you would have been excluded from the population. And then they identified cases through their research data warehouse cohort. So I'm not sure whether people had to sign up for that cohort at the time of birth or not in order to be contacted for the study. They didn't talk about that. So obviously one of the big things in the telephone survey is not reaching people and the issue of convenience sample. In order to try and reduce this, they called every person who had given birth in that time they thought were eligible for the study between 6 and 10 times before they gave up. Whether or not that reduces some of it, probably, but maybe not completely. And then they excluded people who didn't speak English. So you had to be able to converse on the telephone in English. And so that was about 9% of the people they contacted who couldn't participate because they didn't speak English. They excluded people who didn't have a working telephone number or whose telephone number was different than the one on their birth records. So that was about 13% of the people that they contacted. And then they had about a 56% completion rate for people who were eligible for the study. So they did have a large number of people who didn't consent or didn't end up participating in the study. And then one major drawback to the study is they weren't really able to do any analysis of who their non-participants were and what were the reasons that they didn't participate and whether or not it's possible that they had vastly different answers than the people who did participate. So that kind of starts off the study with one of the major grains of salt. It's just interpreting everything. So in terms of whether this population is similar to our population here in Manitoba, they had very much a convenience sample, and they had 74% of respondents who were white and non-Hispanic. 57% had a university degree, so that's pretty high. 90% lived in an urban area, and 33% had an income over $100,000 a year. So those things also make their study pretty specific to the population that they studied. So because this was a cross-sectional study, they didn't really try and find a control group. They were just looking for prevalence and then looking at factors based on what answers people had to the study. So in terms of administering the survey, so it was a telephone survey, which has some pros and cons versus the written survey, but people at least didn't have to come in for it. They weren't remunerated for participating in the study. They had a single person who administered the whole study in order to try and make it similar for everyone. With the telephone study, it is possible that people's answers were misclassified, and they tried to have some open-ended questions in the survey, and ask things in a way that wouldn't lead people to the answer. Whether or not that was effective is also a little bit of a question. I think the rear-facing car seat use, the primary outcome, they did a really good job of asking that in a way that wouldn't lead people to what the right answer was, because they just said what way does your car seat face? And then a little bit, some of their other questions are a little bit more leading. And I think they tried to classify people into groups for the purpose of analyzing the survey, but that made questions if they answered that their car seat was rear facing, they would ask why is that, and then they tried to group people, and because of that I think people ended up having answers that they probably didn't actually say, oh, they were aware about the AAP recommendations. can't believe the number of people that they probably said they were aware of some recommendations, but not specifically the AAP recommendations. But in their survey, they grouped those people all together. So they also got a lot of information on variables like age, gender, race, language, education, marital status, household income, which was self-reported, and then their urban versus rural was done by the zip code on the chart. It's interesting that they used like self-reported income versus some of the other measures that we've learned for analyzing some of these things based on zip code. And then they asked about whether they had a primary care provider, when the last time they saw them, and whether or not they had talked about car seats at that meeting. So the outcome that they looked at was was the child rear-facing at the time of survey administration, and then their secondary outcomes were why the child was switched and what age they were switched to forward-facing car seat. In terms of their statistical analysis, so they didn't do a sample size calculation, which was a little bit interesting, especially if they want to use a prevalence. You'd want to know how accurately they want to know that, but they decided not to include that in their paper. They used a logistic regression to calculate odds ratios, which seemed appropriate for like a dichotomous outcome, and then they adjusted the odds ratio using the multivariable regression model to control for things that they thought mattered, like age, ethnicity, education level, and marital status, which all seemed an appropriate statistical analysis. And then they had no data on their missing respondents. So moving on to the results of the study. So they reported that 62% of the people that they had contacted had their child in a rear-facing car seat at the time of the study. So this was much, much higher than in the previous reported literature. And they didn't report a confidence interval around that prevalence for like what they estimated the population prevalence to be. But a quick calculation, I think it's like plus or minus 4.5%. And then if you guys flip to table 1, that's where most of their results are. And if you look at their odds ratios and their confidence intervals, the things bolded are the ones that they found that were significant. So they found that being white and non-Hispanic had an odds ratio, adjusted odds ratio of 2.2, having more than a bachelor's degree, or bachelor's degree or more, had an odds ratio of 3.2, having annual household income greater than 100,000, living in an urban area, and then, interestingly, they found that if you had previously used a car seat with one of your previous children, you had an odds ratio of 0.6. So you had a lower rate, or you were more likely to have a forward-facing child at the time of the survey. And then they had this interesting, I don't think I've talked about this yet, they had this interesting section of their population. So they had previously done a study where they had gotten a car seat technician to teach people how to properly put in their car seat at the time of discharge from hospital. And because of the timing of their study, these populations overlap. So there's a potential for people who participate in this study to have previously participated in this study where they got this like free car seat technician to show them how to do it and give them information on car seats. And so they measured whether or not people had participated in this previous study and whether or not that made a difference to their having a rear-facing car seat at the time of the survey. The problem with this is that it wasn't really like a part of the original study. So they just like only a part of the population was included or would have participated in the study, and not everyone who participated in that original study would have been contacted for this. And so I felt that including that and trying to decide if like their original intervention as a part of a previous study was working based on this study wasn't really the proper way of going about analyzing whether that intervention was good. And so I kind of disregarded it because they really should try and follow everyone who got that intervention, and not just like contact people at random and see if they were more likely to have gotten that, because it seems like they would self-select people who like participating in studies by doing it this way, and that those people are probably more likely to follow certain recommendations or be aware of new recommendations. And then their provider discussing car seat safety use at their most recent well child check was also significant. And then having a primary care provider specialty in pediatrics, and then knowing the AAP recommendation was also significant. So one of the things when you're looking at all these odds ratios is like they are looking at a lot of things, and even though they're significant, a lot of these things are very close to 1, so like they're very close to not being significant, and especially the adjusted odds ratios. So it is hard to interpret some of these things. And then the other major thing that I was thinking is that I know that they adjusted for a lot of these things to make sure that they had independent effects, but a lot of these things I think go together still and are like things that we know are determinants of health, so I'm not that surprised that they showed up as significant in the survey. And then if you look at table 3, one of the interesting things that I took away from the study was that like the age that at which caregivers turned a child from rear facing to forward facing. So only like 3.3% of children who were forward facing at 17 to 19 months were forward facing before a year. So if you had been following, like the majority of children were following the previous recommendation, and not all of them were following the new 2011 recommendation, but I thought that that was also an interesting result from the study. So one of the questions is, are these results clinically significant as opposed to statistically significant? And I think that some of them are things that maybe we already had a hunch, or like these determinants of health that we often think about. And so kind of just point that those apply in this case. And I'm not sure any of the results were that surprising, other than previous car seat use. Was something that I was surprised about, and the authors talked a lot about. One of the things, so they were more likely to be forward-facing if they had a sibling who had previously used a car seat. One of the things that I was thinking about was the timeline that they did their study. The previous sibling would be under like a different set of recommendations when they were born, and so it's like if you did something with one child, you're probably going to do the same thing with the other child. So I wonder if that would change if they redid the study. In terms of the author's discussion and conclusions, they concluded that a higher proportion than previous studies were following the recommendation, and they identified that this is likely due to their population being pretty specific and sampling differently. And they concluded that having a healthcare provider give guidance about car seat use was important, and I agree that that's probably important, but I think that there is a little bit of recall bias. If like you remember your healthcare provider giving you information, then you're probably, at your most recent visit, you are probably more likely to follow that, but that doesn't mean your healthcare provider didn't say anything, or whether it's reasonable to expect like a primary care pediatrician to mention car seat safety at every visit, or whether it should just be one thing at one visit in the first year. So I thought that that was a little bit of a leading conclusion. And the pediatrician as a provider, I think it's easy to say that like, oh yeah, a more specialized provider will give better recommendations, but I think also people who are very up on recommendations and really want to do, like are very concerned in that way might be more likely to have pediatricians. And so this kind of leads to the cross-sectional issue of like, you can't show any causation, you can only show an association. And I thought that that was likely a finding of association and not causation. And then I talked about the external validity problem with the study population. I think we've talked about the limitations. And the study strengths, they did look at a large number of determinants, and they had a pretty good sample size, despite the fact that it was a convenient sample. And in terms of their abstract, I thought it was reasonable, but they might have overstated their conclusions a little bit. Okay. I think that's it.
Time is perfect, 22 minutes.
Two general questions just around car seats in Manitoba, someone who's not from here. When someone is born here and leaves with their child, do they have to bring the car seat in and show? I know that these are older kiddos by the time they're facing backwards, but is that part of the, do you guys know?
I didn't do obstetrics here. I didn't do that.
Kids?
And then don't kids.
I think 8 years ago we had to.
And then I guess on the same lines, like if pediatricians and we can make suggestions, but also what's available in the community. So often there's, you can go to the fire hall, right, trained, or and those kinds of things. Not that everyone does it, but I think if there's a culture of doing those things, people are maybe more aware of when the standards change or when the things change. I wasn't sure if that was discussed at all.
One of the things they did look at, like whether people had a car seat technician involved, and they also looked at the reasons why people switched. And so lots of people switched to forward-facing because they felt that their child was too tall, or they got a different car seat from their infant car seat, so the one that they had been discharged from the hospital with. So I think that those things are probably important as well. And in terms of the too tall or too heavy, I think that those were also things that had previously been a reason to switch, and so are a little bit confusing.
Wonder if there's a price difference for car seats. I know also like with higher SES where like they're more likely to comply with some of these recommendations, but at the same time it's like a pretty drastic difference between less than $40,000 over $100,000 whether or not they use front or
I was also wondering that, and like the things that I thought that were impossible to measure because I think people didn't respond to the survey adequately who were in those situations is like, lots of people have trouble affording a car seat, and if you don't have your own car, it's a lot harder to install the car seat and use it properly if you're constantly in someone else's car.
they're not cheaper than $500.
A little bit confused on the like recommendations still, because like I have the CPS thing here and they're saying like at least 1 year and 10 kilos.
Yeah, so
but this study was looking more at like they should be in until they're 2 years old. Or
so the CPS statement was written in 2008, and they cite the AAP recommendation in 2008. which was to have a rear-facing car seat up until 1 year of age or 10 kilograms. But then in 2011, the AAP changed their recommendation
okay.
and said that everyone under 2 years should have.
So is
a
our
rear-facing car seat.
recommendation still like behind them?
Our recommendation is behind.
Okay.
Yeah. And so I think in a Canadian context, like, who knows
So here,
what's
kids
happening.
are probably not in rear facing till 2 years. Like, cause this is the first time I've heard of this.
Yeah.
It's all over Facebook.
Oh, okay.
I'm getting to the age where all my Facebook friends have kids and.
So yeah,
I don't have like friends and kids, but I have like Andrew's family, they're having kids, but I didn't realize that like the recommendation was up to 2 years.
Do you think
Well, the AAP recommendation
Yeah,
is up
up
to
to
2
2 years, yeah. But here it's still 1 or 10 kilos, right? 10
well, I don't know, they haven't revised their
They haven't
statement or
revised it,
updated
yeah.
it.
So that's like,
So-
what should we be recommending?
I think the recommendation of up to 2 years is reasonable. Like, I didn't read the studies that was based on, but there was a study that they cited that said that there was a study in the journal Injury Prevention that showed that children under the age of 2 years were protected by being rear-facing. Someone also read the article. I'm not. Habib also read the article, and then someone was also evaluated.
So when I read it, like things surprised me, like calling someone 10 times, too much.
I actually don't think that's necessarily
I
enough.
thought-
If your answer is did they pick up the phone, you could call 10 times in a day, someone's at home. So like, when did you call? Did you call at different hours? Is that actually their primary phone? Do they have an answering machine? Like, it's excessive, but the whole point of this style is that it's crummy and you better show that you've tried.
And it was a very long survey, like 42 questions.
Yeah, it was.
So I don't think it's well. So it's like,
They said it took about 15 minutes,
yeah.
which for a telephone survey is long.
I find it interesting you're saying like that if they called, if their phone number had changed since birth, they wouldn't use, they were out of the study. And I was like, that seems like there's a few things like that when you already have a somewhat, not biased approach, but your approach is already somewhat limited to then just kind of say, oh, well, their phone number changed, we're not gonna.
Well, phone surveys are now almost a weird thing in the past because how many of us even have a home phone?
Right, but they might have had a cell
But people
phone.
put their cell phones
Like-
on.
Whether or not they put their actual.
But that's what I mean, like, to have that
If they've
changed.
changed it.
And who's more likely to have their phone disconnected or not available, or like a certain,
Those are all huge problems.
right?
So how could you have looked at the differences? Because you've identified that they excluded a lot of people, like non-English speakers. They excluded a chunk because they didn't have a phone. Is there any way they could have looked at, does that group differ systematically in any way from those who participate?
It would have been interesting, like, I don't know what consent they had to use the information available on the charts of the people who were non-responders, but presumably there's some demographic information on those charts, and including like zip codes and stuff that they could have done an analysis of the non-responders.
And some RIVs seem to be pretty good at letting that go. I'm not supposed to talk yet, am I? Where they'll let you look at a degree of non-participants' data, others will be more strict on it.
Even just like the language piece, if you're gonna not include people who you can't speak to on the phone, I understand, because you can't ask questions, you can't get answers. But if your whole study's looking at uptake of proper protocols, arguably one group that might be less likely to do that is a group that doesn't, their mother tongue isn't the language they're teaching, and it'd be interested to know.
So someone else that's supposed to critique, I think.
I mean,
Yeah.
so I thought you did a really good job. I thought.
Or
sorry, the
Sorry.
critique of the interview.
Okay, so we spoke about most of them. The other thing that I noticed, like the population, I don't think it's an appropriate, especially with the majority are considered as socioeconomic. And I couldn't understand like the other study, how did it interfere with the results of the primary study. That's what I'm trying to
So I thought you did a good job. I thought
you did a good job of explaining kind of the background because it is a fairly new recommendation and there's been change kind of in the area, and so explaining kind of how it's changed and the recent time was I thought you spent like an appropriate amount of time doing that. I thought that you had some thoughtful critiques of kind of the style of the study. And overall you were well paced and well organized, easy to follow. I don't honestly have much in the way of things to improve on.
So the CPS links to this like Save Kids Canada, which then turns into this like Parachute Canada website.
But it still has the old recommendations.
Well, they have this like, if you go under car seats and they say tips, car seat information and tips, and under tips, number 6 says keep your child rear facing as long as possible. It's the safest position as it protects their weak head and neck. Most children can stay rear facing until at least the age of 2. But the CPS guideline itself still has like.
Because when I looked at the CPS guideline, I linked to a parent website that had the old recommendation.
To a parent website?
To a like a website for parents. But I think.
Maybe they have more than one link here.
Yeah.
But.
So if you could wave your magic wand and keep this as a phone survey, so you can't be perfect. Are there any questions or pieces of information that you think you would have liked to help with this?
Like what piece of information are they not asking that I would have asked?
Yeah. Or are there any things you would have asked?
Like, I would have liked to know what more about like the prevalence of using their own cars versus driving in someone else's cars, and whether or not the child has like what like stage of car seat that they're using. Because I think maybe like when you have a brand new baby, you have the correct car seat and you bring it to the hospital and it's the right type. But I imagine when you're getting around that like 17 months to like 2 years, it's like if your older sibling had a car seat that's maybe no longer built to be the right way, those would be reasons why you would be like, oh, this is fine.
Well, and at 18 months, like, they could have another baby.
Yeah.
And so they could be putting the other baby into the rear facing and graduating their new.
And some people have car seats that are modified for a bunch of different ages versus ones that are just applicable for a single age, and I don't think that they got into that.
So that might have been a good question to ask, right? You were at a score with a dollar value, and I remember again from personal experience, there's a huge range of prices, and presumably a huge range of adaptability to size. And one question that might be worth asking is, what does your car seat say? And how old is your car seat? If you're using the car seat from your kid 5 years ago, the instructions might not say anything, so that's another source of knowing what the recommendations are. If it's a 2015 model car seat, you're probably good.
Or where did you get it from? Was it passed down or not? Not to say that if you have money, you don't take hand-me-downs, but knowing just my friends who all had kids, some of them were just like, well, I'll just go buy a new one. It's an expense, but da-da-da, whereas others were like, I could buy a new one, but if this one that was my cousin's from last year is still good, then it's money saved and spent. I'm going to guess
the,
that
like,
people make those
instructions
choices
look like them still.
I think table 3 is interesting. Why people weren't following the recommendations if they knew what they were.
Yeah. Well, I don't know if they knew what they were. I think it's just the reason why they switched them and the age at which they switched them.
So if you look at some of those things, we too big, too tall. So I think when I read the questionnaire, that's just a question to the parent. but we don't actually know whether these children, what their weights were, what their
Right.
lengths were, what.
And they talk about like feet touching the seat versus being too tall, which like seem like similar things to me.
But if we want to help people adhere to a recommendation, maybe they thought they were too big or too tall, but they're actually
Works, yeah.
not, right? Like that's part of the teaching around it.
Like, this survey was done at 18 months?
At like 17 to 19 months.
Because like, it seemed, I think it'd be cool if they like stratified responses, like switching at 12 months versus those who didn't switch. 'Cause it seems like the most common reasons, like too too tall, blah, 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 it seems like they would switch because they thought they were
Yeah.
so it wasn't appropriate to have them rear facing anymore. Like, but like, maybe those wouldn't be the most common reasons if they were those populations switched.
Yeah, it looks like the biggest thing that I took away from that was that the majority did switch after 12 months. It wasn't like switching at 6 months. The ones who were forward facing were really all switching after a year.
A couple things I wrote down as you were discussing it. So you mentioned they declared that there were no conflicts of interest, but the author was a consultant, unpaid consultant
Unpaid
for
consultant.
car seat companies. So why do you think that it's not a bias in that guy's opinion or in their opinion?
I do think it's a bias
Why don't they think it's a bias?
because he's not paid.
I also wondered, realistically, I'm just throwing this out there, I don't know. So he's pro car seat, you know, it's not really something that's a bad thing, so I'm not
Right.
sure if it would actually,
Would it count as a bias though if he was suggesting that everyone switch to, like if he was suggesting the way in which we do, which might be scientifically based, and then he's doing a study to show that are people sticking to that, like does that count? Not a bias maybe, but that is if nothing else, like an academic.
My understanding is like the car seat does have to be built slightly differently to be rear facing than forward facing.
so my take on it was that, knowing, again, from personal experience, Britax car seats are like the Lexus of car seats. So, and that's who there could be a bit of bias, is, you know, if you buy a more expensive one, it's more adaptable to your kid facing backwards for longer.
So I'm going to be a little devil's advocate. Just throw out an issue to think about. He's declared it. I don't know why he's unpaid. He might have said, I don't wish to be paid, because that's a different degree of involvement. I'm bringing this up because I guess I struggle with this. We need experts to advise people. Companies, in my world, it's diabetes. You know, you may choose not to be part of an advisory board because you don't actually think they have any input. But if companies don't ask for expert input, they're going to be, so it's a bit of a catch-22. I don't actually have an answer, but I throw it out there for thought, because if you choose to provide expert input, should that exclude you then from any research or editorial board or whatever? That's a pretty big decision. I wonder whether he's unpaid because he's chosen to decline payment to try to distance the perception. I don't know, but I throw that out there because it's a bit of a catch-22, right?
I think that point's really well taken, because often when we're being taught how to do journal clubs or to read the literature, we're always told it's bad if, like, bad pharma, bad, and like there's a lot of bad, it's not pretending there isn't, but ultimately your point is well taken, and so you can declare and you can do things in how you do your study to prevent your bias from stepping in, and we're humans, we're capable of that, but the assumption that if someone is paid anything is a reasonable. That's good.
Anybody have questions before I ask him? They asked some open-ended questions, right?
So it was
So what did they do with
unclear
those?
to me how they asked the open-ended questions.
Or how did they look at them?
Because it's a telephone survey, so if you look at the survey, like, how did you learn to install the car seat that blank is using now, is a question. But then next to that, they have a bunch of, then it says check all that apply, so I assume the person who's doing the telephone survey is listening to them and then categorizing them into like online resource, taught by friend or relative, taught by a nurse or healthcare worker, taught by a physician, read a car seat manual, self-taught without car seat manual, certified car seat technician, unsure, caregiver did not install, taught by fire or police, car seat information, safety fair, help from retail location, other. And so I think that the person who administered the survey checked off the things that they categorized on the phone that the person was saying, but they didn't do like, I don't think they took transcripts and looked for themes or like those, that would be another way of looking at the answers to an open-ended question with a more qualitative lens. And I think that that would give different answers than kind of having these set things that you're trying to categorize people in. Because that was one of my problems with their aware of the AAP recommendations. I didn't think that people were coming up with that on their own. I thought that someone was classifying them into, I was aware of the AAP recommendations when maybe they were just aware that that was what was recommended.
I actually have one more question, then I'll shut up. Because I'm practical. So I'm going to go on the assumption, because I have not looked at the primary justification for the AAP recommendation. Let's assume that that's a well-informed recommendation. You have some information about use of it. So let's say your goal is to get everybody doing that. With the information that you have, what can you use this to increase the uptake of the recommendation?
So I think their goal was to identify populations where the uptake was lower and then be able to target interventions to those populations. And I think that that is a reasonable goal in looking at determinants and then trying adjusting how to try and increase your uptake. And I think that they did identify some determinants. I'm not sure if those were things that you like necessarily needed this whole study to identify, because those seem to me to be determinants of lots of different health knowledge. But I think being aware that it's important what people say in their healthcare visits, and it's important particularly for people who might not have the education or health awareness to be looking for those recommendations on their own, was the takeaway that I took. I don't know if other people have thoughts about that.
I guess how would it inform what you do?
Yeah, so I think it was interesting to read, and it will like probably change my recommendations, because before reading this I was unaware that kids should be rear facing till 2 years, and I will put it in something that I will do as like an outpatient primary care clinic, and I think for me personally that's how it will inform my practice. I'm not sure if it will do that much else.
Just as an FYI, the actual initial stuff that was published, I guess it was 2007, I remember it being quite a while ago, was a huge reduction in morbidity and mortality out of maybe Finland, I think, or one of the Scandinavian countries. So that's the standard there. I think they go for years. I want to say 4 years. Rear facing. So by then I'd be getting car sick.
And your feet are in the window.
So I just have one quick question about telephone surveys. How would you improve enrollment if you're not happy with what you're getting and you're, I've called them 10 times?
So using the telephone to reach people is like, I think just difficult in and of itself, but if you're restricted to a telephone survey, I like the fact that they did phone 10 times. I wonder if there, like sometimes there are multiple phone numbers in the chart, whether they can go like mom and dad have different numbers, like try both. And also the fact that they were using numbers that had been given like a year and a half ago is not really the best way of reaching people, because people change their numbers all the time for a variety of reasons.
You could almost argue that's a socioeconomic marker. People change the number all the time.
Yeah.
Probably as well. You caught me there a little bit because you mentioned if you were restricted to a telephone survey, I guess other means that you could do a survey like this.
So you could look at like a cross-sectional survey. You could look at everyone who is like presenting to a primary health clinic, or you could look at contact people through some sort of like mail survey. Like all those things have their own drawbacks, but
Combination.
yeah, you could add those things to each other.
This actually, I don't think is a very bad response rate. Yeah. Again, it's probably most weeks I think it's more upper middle class that you're getting. What we have done for a couple of studies is we get a hold of people by telephone and then say, would you prefer to complete the survey by telephone now or at some other date?
Or email.
We'll call you tomorrow at 4 o'clock. Or would you go to this website and log in and do it?
Yeah.
And the other thing is, that if this was a resident research project, this would be optional, but it's bribery, right? So when the survey is completed, here's your PIN number and you activate a $5 Starbucks card or something.
Yeah, that would be
People
good.
sell their soul for $5. Kathy Budison, a PEDS Emerge researcher, says Emerge physicians are pathetic. They'll do anything for $5.
As long as it's coffee, right?
A friend of mine did a huge research project in Nova Scotia, but it was with doctors, and she literally taped toonies on the front of everything and had one of the best response rates ever. And it was literally like the guilt of getting the envelope with the toonie attached to just fill in this quick survey, and then they'd follow up with like a thank you. and
Guilt is a good motivator, is that?
But
That's
it
my
would, like-
parenting style.
But yeah, no, she was like, the response rate was crazy, and like doctors are notorious for not answering. It was just like the simple act of a toonie taped. I remember helping her taping it on, like, it's crazy.
Jonathan, we're nearing the end, and I really appreciate the effort you put into that. I'm just going to throw out a couple things when you think about writing up your own work. And it's always hard because editors will come back and say, cut, like shorten. So it's easy to sit here and criticize, but there were two things that we haven't talked about that when I was reading, I said, why did they do that? And I would have liked a one-liner, even that this was all we could do. So the choice of their enrollment period, like it was like November to, why did they choose that particular enrollment period? I don't know, maybe there was a reason.
Sounded like the person who was doing the surveys had been hired for like a
So-
fall.
And why did they choose the particular age group? I mean, they might have said, well, 17 months was, like 17 to 19 is like 18 months, which is halfway between a year and 2 years. Maybe that's what, I don't know, but I would have liked a one-liner, and I appreciate that might have been there and gotten cut, but when I write, I try to not get questions. Do you know what I mean? I try to put as much without it being, because you've only got so many words, but things that would be obvious questions, why it can sometimes be done in one-liner, so I just throw those things out. I'm not sure why they chose that time frame or that age group.
I thought they said something about it here.
Well, maybe we did, but I didn't.
Definitely not the time
Maybe
frame.
not.
But thank you, I appreciate the time you put into that. Now, I know we have a second article. Do you guys want a bathroom break?
They're okay.
I don't know.
When they need to.
Do you know what their bladder status is?
That they go out with.
Okay.
That was a pre-run.
And they're gonna get another, they're gonna give me 10 o'clock when we done.
Celia does not let you pee, so. That's one for everybody.
Those are coffee drinking.
Yeah.
No, they're good. So who is?
Can I throw one more fast thing in there? Is, Jonathan, you mentioned about when the odds ratio is close to 1, 0.9 or 1.1, right, the side of 1 is really close. Does that mean it's almost statistically significant? Yeah, because that's one of the things that people will say, oh, it's so close to significant that it must matter. But I think it's meant to be a yes, no.
Yeah.
It's not. It's tempting all the time. And you want something to work and it shows it's odds ratio of 1.1 to 12.
Or you read the results that say girls were more likely to do this than boys, though this didn't reach the statistical significance.
Growth chart.
Preference?
Oh, the article name inside Dropbox.
Oh, okay.
But it's physicians and physician trainees rarely identify overweight and obesity in hospitalized children. Shall we wait for Duncan to come back? Just because he's my okay person.
Is it a synergy?
Is that the overweight hospitalized kid?
Yeah. I think it's called growth chart.
Really address overweight.
We're just all waiting for you.
So just so everyone's aware, it's colder here than in Churchill today, and it's not that cold, I acknowledge. And tonight there's going to be rain and flurries.
I'm going to lake tonight.
Cyclocross race tomorrow, perfect.
Okay,
You want snow?
I spent my weekend where they had 2 feet of snow.
Oh, is that? Really?
2 feet of snow.
Is it kind of stupid?
Well, it's gone now, but,
It came and went.
well,
It heard you were coming.
Last year.
It's still summer in my mind.
Bring it on.
Oh no. Like a bad one. Like her doctor's like, not. Yeah, she was driving because she was doing her practicum in Carson, just like an hour away, and so like driving home on the highway.
okay, you want to get started?
Okay, so the title of the article is Physicians and Physician Trainees Rarely Identify or Address Overweight, Obesity in Hospitalized Children. This was published in the Journal of Pediatrics, which has an impact factor of 3.84 in 2016, making it rank 6 out of 120 for journals classified as pediatrics. Okay, so the rationale for the article and source is timely. Obesity is a rising problem in pediatrics. So in Canada in 1978, it was about 15%, and in 2004, it's closer to 26%. And as stated in this article, hospitalizations may be an important setting where they come into contact with physicians, and especially for those that may not usually go to a primary care provider. And it's a good time for us to address obesity or overweight in these kiddos. As I mentioned, the journal quality and impact factor already. Potential conflicts of interest. The authors have declared none, and they don't have any sponsors. I tried to look them up, and it didn't seem like they had any specific conflicts of interest. The first author is Dr. King. She's a hospitalist in Gen Peds. Her interests includes medical education, complex care, and management of obesity, and she's from St. Louis University School of Medicine. The principal investigator is Dr. Mihalis.
She's a dual-trained GIN and pediatrics physician. Her interests include adolescent medicine and preventative cardiology, and her main interest is obesity, heart disease, and eating disorders. She's an associate professor at the University of Utah. So these are qualified individuals to speak about this topic. Their primary question here, I'll state it in it's on the first page, and it's to determine how frequently physicians identify and address overweight or obesity in hospitalized children. Their secondary goal is to also to identify whether or not there is a difference in documentation across levels of training when they're med student, when they're intern, when they're senior resident versus when they're staff attending physicians. So the type of study is a retrospective chart review. Normally I know we're used to the PICO format, but it'll be a modified PICO or in a PI format. The population we're interested in this study is children 2 to 18 years who are overweight or obese, admitted to PCH general medicine or general pediatrics ward between January 1st to December 31st of 2010. The intervention was a retrospective chart review, and the effect or outcome they were evaluating is number 1, % of hospitalized children with overweight or obesity actually documented in their chart. And the secondary outcome that they were interested in is to see the author who documented it, so what level of training they were at. And there was appropriate ethics approval at the University of Utah and the Intermountain Healthcare Privacy Board. So for the patient selections, these were all selected from a database, the Intermountain Healthcare Enterprise Data Warehouse, and what they extracted was the age, sex, weight, height, race, primary hospital service, length of stay, and discharge diagnosis for the individuals that are between 2 to 18 and who are already identified as obese based on their BMI recorded on the chart. That's mandatory for the nursing staff to document when they're admitted. And their exclusion criteria is 1, if they were missing the weight or height and you can't calculate a BMI, or they deem that that height or weight is physically impossible by Grubb's outlier test. So I had to actually look that up. It's a test that assumes everyone falls under a normal distribution, and it's excluding any beyond the tip or maximum from the data set that you're looking at. And I think the patients that they selected were reasonable. These are already kids who were identified as obese based on their documented BMI from the nursing staff, and just to see whether or not physician staff have actually also mentioned it or addressed it in their hospital stay. So I thought their inclusion and exclusion criteria were appropriate as well. Their inclusion criteria is very broad, just includes everyone between 2 to 18, so pediatrics, that was obese. They excluded anyone under 2 years, presumably because the way we look at obesity is different. We usually do a weight and length proportion to age when we plot their chart, and they start to use a BMI after they turn 2. So their age that they selected is appropriate, and the reason for exclusion is very fair. Like if you haven't documented it, then you can't comment on it. Baseline demographics. So they said that it's generalizable because it's everyone that's or generalizable to patients that are admitted to tertiary care centers. Their average obesity rate was about 20% in the sample, and but this might not be applicable to remote areas. So it seems like it's more of an urban population, whereas in some of the more rural areas where food is less accessible, your rate of obesity may be a little higher, so it might not be generalizable to that population specifically. I thought the discharge diagnosis, if you look at table 1, it's very applicable to our patients. It's what we see, like bronchiolitis, cellulitis. It's very common reasons for kids to be admitted, and I think it's across the board very generalizable. It's in the appendix.
Okay.
Like you have to go all the way to the bottom. There's a strong bias towards the Caucasian population, and it might be different if you document in the Aboriginal population support, so it might not be so generalizable to that cohort. So that's regarding the baseline demographics of the patients they recruited and whether